I'd like to introduce Tixel technology to you. Tixel is a fractional system which applies thermal energy, which is delivered to the skin by contact. We call it delivery by conduction. Here we can see how Tixel delivers energy to the skin. In this clip, we see a hot tip made of titanium, touching the skin very, very briefly and transferring heat energy, thermal energy to the skin, which in turn rejuvenates. The tip does not make a hole in the skin, does not protrude the skin, it simply contacts the skin to create a thermal matching and thermal transfer. This is very similar to what we do when we iron a shirt. When we iron a shirt, we have an iron which is hot, and we move and transfer the heat in motion to the cloth. The faster we move, the less energy is transferred. The slower we move, the more energy is transferred. This is exactly what we're doing. The tip that we see here is covered by a titanium shield, titanium material which is biocompatible. It is always clean and always sterile. It is reusable and is non-stick, nothing sticks to it. So it's a very clean system. The temperature of the tip is kept at 400 degrees centigrade. The tip is heated by a ceramic heater which is small and is attached at the bottom part, on the back of the tip to it, and the temperature drop from here to here is only 7 degrees Celsius, which means that the temperature at the edges is 393 degrees centigrade. The effect on the skin are white spots. There is no carbonization, no burning. We can create by long pulses, 14 millisecond pulse duration, ablatives effects on the skin. Here we see that there is no epidermis. This is an ablative effect. Or shorter pulses, 10 milliseconds, are used to create non-ablative effects. 7 days after, this is a histology of pig skin. 7 days after, we see fibroblasts and macrophages which proliferate and create new epidermis. And the treatment area is in the final phases of healing. This is a mathematical model. It shows us that the tip contacts the skin in motion but does not make a hole in the skin. Upon contact, energy is transferred from the tip to the skin. The tip has 81 pyramids, 9 by 9, 1 centimeter square area. It pushes the skin and the skin recedes. The control that is provided by the device is concerning the speed of the motion and the distance of the motion. The faster the motion, the shorter the contact time. The slower the motion, the longer the contact time. So if the tip moves very fast, there is just very little contact time. If it moves slowly, there is longer contact time. The longer the contact time, the more energy is transferred to the skin. Thinking about a candle and the flame, if we move our finger slowly, we feel hot. If we move fast, we don't feel anything. So this is very similar, very quick or very slow. So controlling speed gives us direct relationship to energy transfer, to the amount of energy transferred because of exposure time, contact time. Distance can be this, very delicate contact, or this, strong contact, which means pushing the skin away from the tip. The more we push, the more thermal matching we have, the more energy is transferred. For thin skin, mostly here, we use low pushing, low protrusion. We call it protrusion, low settings. For thicker skin, we use more. Just like when we iron. If we iron a shirt, thin cloth, just very quick. Thick cloth, push, press. That's the same concept. This is the tip, hot, and this is the skin layer, and this is 100 microns below the skin. What we see by the mathematical model is that the temperature drops from 400 degrees at the area of contact with the skin to 50 degrees in the papillary dermis, 100 microns deeper, which is very safe because the temperature drop is steep, is rapid. That means that we don't create very high temperature in the papillary dermis. And that's why treatment is very safe. There is also low pain. And there is no carbonization. Why do we have temperature drop, which is so quick, from 400 to 50 in such a short distance? It's because when a hot element touches skin which contains water, it's hydrated, the first thing that happens is that the water vaporizes. The water exits, it leaves the system rapidly. Water vapors carry the heat with them, so the temperature does not go up beyond 50 in this area because the energy escaped. That's a very important feature of the technology. Why don't we have carbonization? Because there is no explosion associated with temperature transfer, and there is no air. The tip is hot, but it is contacting the skin. There's no air in the area of contact, so we cannot have an explosion. Not having an explosion means that we don't have carbonization. Not having carbonization implies that we do not create pain and that the healing is fast. So we have many advantages, just to summarize, simply because of the way we transfer the heat. Anaerobic conditions, no carbonization, escape of water carrying out the energy away from our interaction area, and as a result of this, low temperatures in the papillary dermis and high temperatures in the stratum corneum area. This is what makes the system work for the benefit of the patient with low pain. The heat is transferred to the skin uniformly, irrespective of the chromophore. Absorption of heat is not related to the material itself, the water or the blood or the tissue or the chromophore. The chromophore is not, or the pig or the melanin. The chromophore is not a factor. We're heating up the whole tissue. Unlike lasers, which are ablative lasers, which are associated with an explosion, in our case we see what I mentioned before. Water vaporizes, and it escapes, it leaves the system, carrying the energy with it. Okay? The temperature of an ablative laser can rise up to 900 degrees. In our case, the maximum temperature is 400 on the surface and 150 in the depth of 100 meters. So this is a drop from 400 to 100. This is temperature and this is time. The skin cools down after about 10 milliseconds or 15 milliseconds, so we can apply the second pulse. This means that in terms of thermal relaxation time, just like in laser, we always look at thermal relaxation time. We are ready for the next shot, for the next pulse, because the skin cooled down. This is how heat, the thermal wave, transfers from here to the skin in this form, similar to the way that is transferred in ablative lasers. The thermal wave is the same. In terms of the amount of energy, it's very important to notice. A laser creates 1.5 joules per centimeter square. In our case, we create 0.025 joules per centimeter square. There's a very big difference. This is 1,500 millijoules per centimeter square for the laser, and this is 25 millijoules per centimeter square for the laser. So the amount of energy the Tixel employs and transfers into the skin is much, much, much lower than the energy that the laser transfers. This is why, again, it is a safer procedure and the pain level is low and the downtime is short. The tip is sterile according to an ISO standard. This is the standard. The tip is sterile effectively at all times. It is sterilized initially by the device automatically, and then between every pulse it re-sterilizes itself within a very, very short period, so there are no microorganisms that remain alive on the tip. This is important in particular because of Staphylococcus aureus, communities of which are found on the skin. Staphylococcus aureus is a bacteria which is resistant to antibiotics. Having a sterile system means that we are not contaminating treatment sites with Staphylococcus aureus. This is another interesting advantage that we have. Re-sterilization is very fast. We can discuss this separately if anyone is interested. This shows that within a fraction of a millisecond, the tip re-sterilizes itself. So what we have is a tip touching the skin. Once it rises, even if there is debris on the tip, it immediately disappears and vaporizes, and everything dies. So that by the time we make the next pulse, the tip is already sterilized again, automatically. This is one presentation about thermal matching. I'll now talk about transdermal delivery or open channels. Okay? The issue of permeability of the skin to hydrophilic molecules, water-soluble molecules, was studied by us and published in a paper by Professor Sintov and Dr. Maya Hoffman. Professor Sintov works in the Negev University in Israel, Dr. Maya Hoffman in Charité in Berlin. And the study showed that after treatment with Tixel, the skin is permeable to hydrophilic molecules, which is otherwise not the case. Hydrophilic molecules do not penetrate the skin. When it is untreated, it is well known. This is because of the stratum corneum. The stratum corneum layer, which is the dead skin layer on top of the skin, this is the stratum corneum here, is impermeable to hydrophilic molecules. It's known in the literature. If there is a need to open up the skin for uptake of hydrophilic molecules, the stratum corneum must be damaged or removed, opened up. It has been shown in literature by Prusnitz 10 years ago that if the stratum corneum is subjected to high temperatures for a very brief time, it opens up. It becomes decomposed. So by heating up the stratum corneum momentarily like this, at very high temperature of about 400 degrees, it opens up. It breaks. The stratum corneum, in effect, behaves similar to cornflakes. It's funny, but yes, cornflakes, because if we take cornflakes and wet it, it is not brittle. But we know that when we dry it, it becomes brittle. The skin has a protective layer which is made of dead cells, and it has been shown in literature that if they are dry, they become brittle and they break. These stratum corneum cells. What we are doing with the tip, drying and pushing and breaking. And this is why we create channels. This movie or clip shows what I just said. The tip will come from here, and it pushes the skin and dries it. The vapors escape, and we are left with an open channel. If we apply water on it, it will be absorbed into the skin very quickly. And with it, our vitamin or whichever hydrophilic molecule we have in this water. Let's take a look step by step. First step is dehydration and stretching. What is happening? The tip pushes the skin, and as we see, the vapors are pulled out or pushed out, escape, very, very quickly. The skin is now stretched. So we have a stretching mechanical force applying on the skin, which is dry. And this is what the literature says. If you dry up the stratum corneum, it will decompose, it will break. And this is what happens, it breaks. Underneath we have a little hole and some coagulation, but not full coagulation, just a little bit of coagulation because the contact was very brief. This is the histology corresponding to the clip. In the histology we see 10 milliseconds. We see that the skin is basically exposed. All this area is damaged in terms of stratum corneum, and this area is not damaged, but it's dry. Therefore, if we apply liquid here, according to Fick's law, which provides an expression of the rate of transport of liquid from an area in which there is high concentration to an area in which there is low concentration, we know that according to Fick's law, the transport will be high. Just to summarize, after the contact of the tip with the skin, we have created here a dry area. And we have damaged the stratum corneum. So if we now apply water, the water would go in. If we have vitamin in the water, the vitamin would go in with the water. This is very similar to what we're doing in the bathtub. If we have a sponge in the bathtub and we are washing our skin, normally we would squeeze it to let the water out so that we can put soap and water on the sponge. It will be absorbed, soap and water, and then we can reapply it. It's exactly the same process. The rate of permeation of water onto the sponge is dictated by Fick's law. Very simple. So here we see what happens. Low water content, and the water that is applied on the skin can permeate inside. The study showed, and I'm just doing it very briefly, that vitamin C, for example, does not penetrate untreated skin. But this is treated skin, and it goes into the skin. The concentration builds up. It also showed that the channel under confocal microscopy remains open for 6 hours. We see inside the skin fluorescein material that we applied 6 hours post. It went in immediately into the skin. Within 2 minutes it was inside.
So it's convenient to order to your patient to apply some?
Yes.
After the treatment at home?
Yes. You can administer it after the treatment, and that's one of the advantages. For example, when we talk about melasma and hydroquinone, we apply the topical first immediately after treatment, then the patient continues with the Kligman at home. This is part of the study. It shows that on 6 volunteers, the channels remained open at least 6 hours. In CO2, the mechanism of transfer, of creation of open channels is different. CO2 drills a hole. There is a secondary coagulation layer around the hole. The hole serves as a reservoir. Here we see the liquid. The liquid has to absorb to this secondary barrier, and from this barrier to the skin. The coagulated tissue absorption properties are slower. The properties are slower than of skin which is not coagulated. Just like hard-boiled egg. Hard-boiled egg would not absorb water quickly. It would take some time. And this is why we think, and we hope to prove it soon in studies, that our absorption rate, the way we create open channels, is faster than in this mechanism. But we have to prove it. We're working on it. Okay, some results, clinical results for combination with drugs. This is an example of hypertrophic scars, which have been treated, this is before, have been treated with Tixel, and on top of the treatment area, the doctor applied triamcinolone and 5-FU, a ratio of 3:1. 1 triamcinolone, 3 5-FU, and rubbed it in. So after the application, we rub in the solution. Another case is keloids. Same technique, rubbing in the triamcinolone 5-FU, and the keloids are flattened. Later on, this can be treated by laser to whiten it. Here is a case of melasma. The protocol is written in the material that we have. This was treated by Kligman, modified Kligman formula that the doctor prepared, Dr. Adina Margaritesco, and she has results which are good. The patients are very satisfied because melasma clearance is substantial. Although we will have to treat again because melasma reoccurs. This is a case of melasma in Singapore with tranexamic acid instead of hydroquinone. This is another case in Israel with tranexamic acid. And this is rosacea. This will be published soon. This is new research by Dr. Ofir Arzi from Israel, which shows that if topical Botox is applied on the skin after Tixel, diluted Botox, the effect is to reduce the rosacea, and this stays for about 6 months. That was the measurement time, and they showed that the level of rosacea dropped significantly during this period. When it reoccurs, retreatment can be performed. The explanation is in the paper. What is the function of Botox on tissue when it permeates the upper layers of the skin? We're not talking about Botox in the muscle. The paper explains that there is effect on the peripheral nerves, which in turn creates some interaction, which affects the microvessels, which contract. You will read about it in the paper. It's going to be published soon. But this is just one case of several that appear in the paper. This is another very interesting case, hemangioma, treated in combination with Tixel. It's just the first case. It's not for publication yet. It's just for training purposes. This is another case of burns, which the doctor treats with triamcinolone and 5-FU. This is another new case which is not published yet. It was presented in a conference. This is rapamycin. So rapamycin will be applied on the skin after treatment with pulse dye laser to prevent reoccurrence of the capillaries, of the blood vessels, of the capillary blood vessels. All this is showing us that we have different opportunities with this technique, and we're exploring many of them. In this case, we see an immediate effect, which looks as if it was a Botox treatment, but it isn't. This is treatment of Tixel before. Immediately after, we applied hyaluronic acid on the skin, that's all. And you see that it's absorbed, and the skin becomes swollen. And the skin is now has a high fluid content, high water content. So this is a nice way to dehydrate the skin immediately after treatment, which is an important feature to dehydrate the skin, important treatment. Just shows demonstrates the fact that there is good absorption. Okay, these are the first two presentations, one about heat transfer, the other about open channels. Next, I will show the protocols and then some befores and afters, and that will be enough. I'll show the protocols. It's a very small, short presentation. How do we treat? Before treatment, just clean the face. No makeup. It is possible to mark with a dermatological pen, like create these marks. The intention of the marks is to divide the face into sections. Each section is treated in turn, completed, and then we move to the next section. This is a technique which our trainers use. Performing treatment. Treatment is according to these protocols. Now I'm showing the maximum settings. Looking at skin types 1 to 3 and severe photo damage. We use the highest setting, which is 14. 14 and 700. We typically do not use more than 14 and 700 on the face. Single pulse, 20% overlap, no EMLA, preferably no EMLA, moisture 4 times per day for 4 days. Makeup after 2 days. 4 treatments once a month. On the eye area, we can use 6 treatments using the periorbital handpiece. Maintenance can be done at lower settings once, 4 times a year, once in 3 months. If we have skin types 1 to 3 with insevere, with mild wrinkles and mild photo damage, we can use 12. We don't have to use 14. Okay? So we don't need to apply high energy, which is 14. It's pretty warm. I'll show you a clip how treatment is made. We can simply do 12. Skin types 4 to 5, we reduce the energy a little bit to 12 and 400, protrusion of 400. Otherwise, there is no difference. Skin type 6, we reduce to 10. Acne scars, typically on the cheeks. Skin types 1 and 3, 14. Skin types 4, 5, 12. Skin type 6, 10. In the case of acne scars, we can do a second pass. We do crisscross. In the case of severe wrinkles, if we have a wrinkle, in this case, we can do crisscross also on the wrinkle, a second pass on the wrinkle itself. Not necessarily on the whole face, but where the wrinkle is. Okay? Transfer more energy. Open channels is from 8 to 10 and 400. We recommend to use approved injectable formulations, which will be applied on the skin after treatment, rubbing them in, and can be then later on applied further at home for a few hours. This is the open channel, sorry, I jumped. Okay? So that's the protocol. Very simple. You have it in your... This is just thermal, without adding any drug or mesoproduct after the treatment. Just thermal. So we have 3 cases that we're looking at: periorbital, rejuvenation and tightening, and acne scars. I'll just show a few cases. Here we see periorbital treatment. First, let's look at the wrinkles under the eyes. They're much improved. Then we see the eyelids, the upper eyelids. They shrunk, and we have a better definition of the eye. That means we're doing something which is close to blepharoplasty without being invasive. Here we see a case which is very good, in which treatment was in combination with tretinoin and HA and some Botox on top. But in general, we can get very good results by treating the eye area with Tixel. This is another case. And this is another case. Look at this area. Okay. Next set of slides is about rejuvenation. This shows the power of the technique at high settings. Not only, and this is important to notice, that at high settings, the effect is a multiple effect. Not only skin texture, not only wrinkles, but we also get nice tightening. So let's look at the neck, for example. Or this area here. And of course the wrinkles and the texture. We get a combination of results because we're using heat. And we don't rely on cocktails or other additives. Just use very uniformly applied heat, 3 or 4 treatments. This is 7 months post.
Just a question, doctor. Around the mouth, you use a second? You can use twice?
You can always do twice if you want. There is no fear.
Okay.
It all depends on the condition
Okay.
of the patient. Obviously, you're right. For severe cases, we should do more.
Okay.
We should do a second pass. But this patient has skin type 3. There's no problem. This is, of course, a great success, but we also have other patients which have skin which is damaged, and now it looks fantastic.
Yes.
And here we see the same. Here is another case. And now let's go to another category, which is acne scars and active acne. Active acne, if it's not severe, we can treat mild acne on acne scars. We have very nice results from India. And this is from Romania. This is 1 year post. This means that this result lasts.
And why is that?
Why?
Yes.
Why does it keep on?
The acne, the active acne.
Why does active acne respond?
Yes.
Because the tip is hot.
Yeah.
The tip is sterile, as we said. If the acne is not severe and we just have a manageable few sites which are inflamed, what we see in practice clinically is that it dries up. It doesn't transform the infection from one site to the other. It creates an inflammatory effect. The inflammatory effect probably results in releasing of the pressure and the blockage, and that's what we get. Maybe the heat helps the acne to open up. This is a very challenging case for us. We really want to do a study to be able to document this
Maybe
statistically.
It works the gland, maybe it works the appropriateness.
We don't know exactly what happens, but we
Yes.
see good results, except in severe acne, which we don't touch.
Okay.
So if you have a severe case of acne, you can first treat it
Yes.
with Roacutan, as should be, but then later on you can switch to Tixel. This is in Japan. It's a very nice case. This is in India, just the scars. That's without any additions of topicals or drugs. Now, the last presentation just showed a few cases, lower settings, which is important, followed by hyaluronic acid and peptides. So when we talk about combination with mesotherapy products, we can use Filorga, all these names. Different companies make different formulations. We want them to be clean and injectable, preferably CE marked formulations, so that we know that these are injectables that have been checked as medical devices. In terms of results, just a few. This is before, this is after, followed by HA application. Here we see the settings are very low, and we see very nice results. Okay, before and after. Including acne scars. This I just got today. This shows us, this is 3 treatments 6 months after at 12,400 of the neck. And this is another case, 1 treatment.
One treatment.
Yeah. So this is followed by skin image product. I just got it today from that's from WhatsApp, but we're starting to see results in the neck, which are very interesting. This is an area which is known to be difficult to treat, and it's very interesting, and I encourage everyone to start looking at this. Okay, this is my part. Thank you for your patience. And we have a footage which is very good. Now we can talk freely. So, any questions? Anything we have to discuss? Many questions? There are several diseases are actually autoimmune diseases, and it's psoriasis is one, melasma and acne we think are another. We have a whole discussion with our panel of experts, of doctors about this, and we are looking at doing studies in this direction, but we didn't do them yet. And this is something which is challenging medicine, challenging dermatology, not just us. So what we're saying, although we're selling a device, we're not really able to say what is the extent of success with all of these indicative cases. These are first cases. For example, I can talk about dry eyes. When we speak about treatment of the periorbital area, we see now good results on patients that have dry eyes with just one treatment. Very simple. I can't really say yet because I need the paper. In 2 weeks we will have the results because it's very fast. We already have 20 patients, and the first 5 that were treated and came back were very happy. So it seems to work on dry eyes. But again, psoriasis, dry eyes, active acne, hemangioma. There's so many studies that we need to perform, and we need time for that. But the doctors, unlike us, the doctors are authorized, because a doctor is a doctor, to look into these things and to try. If they have a patient that doesn't respond to anything and he has active acne and is willing to take a shot, maybe it'll work. And that's what we see. We see that we can improve. In many cases, we can improve the condition of patients. This is why I'm presenting all this data, because we want people to start to explore. And that's the fascinating thing about the device as well.
Raphi, could you please explain how it works in dry eyes?
Dry eyes, we have glands here and glands here. Dry eyes, it's a situation or case where the glands are blocked. Okay, so the blockage of glands is caused mostly by the fact that we don't blink enough. There are different reasons in the literature, but the most common occurrence of dry eye is related to the fact that we sit in front of our computer and we don't blink. When we look at a short distance, we don't blink naturally. The instinct doesn't work. That's what the ophthalmologist explained to me. When we look further on, our instinct then is normal, and we activate our blinking instinct frequently. We moisture the eyes. But what happens when we don't blink properly? The glands are becoming blocked, and we have to release them. Releasing them means heat. It's been shown in literature that if we apply heat on the glands and we create an inflammation, they start to function properly. So we tried it, and we're seeing very nice results. And it's very simple. One treatment is enough, here, and it works. But no statistics yet. I don't know if the first 5 cases are good and the next 10 will not be. But so far the doctor is very excited.
Do you recommend a specific moisturize after there is specific
The simpler the better, just moisture.
Okay.
The simpler the better. No, nothing in it.
Okay. Doesn't have
The
any-
best is hyaluronic acid, as far as I'm concerned. As far with ISO, we just apply hyaluronic acid on the skin, it really absorbs. Just dripping it. Okay, this is a presentation which explains what protrusion is. The tip is homed here, 2 centimeters away from the skin. So there is no heat radiation to the skin at this distance. Okay? This is why the tip has to go back, otherwise it becomes hot. And when we move forward, the tip protrudes through beyond the distance gauge and touches the skin. The measure of protrusion is the distance between the distance gauge and the edge of the tip. That's what happens. We measure how much it goes out. This is more, and this is 100 microns, 300 microns, 500 microns, and 800, etc. So if the tip pushes all the way out 1 millimeter, the protrusion is 1,000. If it pushes only 100 microns, the protrusion is 100, and it's 0.1 only. This is 700. What does it mean to us? It's again goes like this. Let's say this is the skin here. The skin here is thin and there is bone. So obviously if we would apply a protrusion of 1,000, we will feel the handpiece going up. It's like when you drill against concrete or you drill against plaster. If you drill against plaster, you go in. If you drill against concrete, you feel that you're being pushed back. So on bony areas, you don't put 1,000 because it will not let you go in. But on soft areas, you can go in. So if you want, for acne scars, you want as much energy as possible. You want as much protrusion as possible because the contact is good. And you push it further. That's why we use, in cases of severe photo damage and severe wrinkles, we use protrusion 700, as you noticed. But around the eyes, we use 400 because the skin is thin here and there's bone. If we push 700, we will really create some, not damage, but it will hurt more.
What is the maximum deeper? The deeper maximum?
1,000.
1,000?
There is any situation you use 1,000?
Stretch marks.
Stretch
Not
marks.
on the
Okay,
face.
for stretch marks.
On the body.
On the body.
Not on the face.
No.
On the face, what is the deeper maximum?
700.
700. Isso é importante, viu, Luciano?
Seria
Tá, isso é muito
só
importante.
vai usar no caso de
Anotando,
cicatriz de corpo, nunca de
Chega até 1.000.
And the stretch marks, you can perform a double test on it?
Yes.
Yes.
Stretch marks is fibrotic tissue, right? It is a layer of dead tissue which is very thick usually, and we have to put as much energy as we can. You won't cause damage.
What's the parameters you use?
Our customers use 14, even 16. You will feel it, but at high settings you're creating a thermal effect and probably some ablative damage too to the tissue. And they're telling us that they have good results. I can show you while we're talking, this can run a clip, a training clip, which I recommend by Mark. Mark Uris is our trainer in Europe. He is using Tixel for a long time now, for over almost 2 years. He is a laser guy, what they call. He's using lasers for 30 years. So I came over to his clinic and I simply shot this, and we put subtitles and everything is explained. It's only 15 minutes. I propose that you sit down and listen to this. Most of what he's showing is the ablative treatment, including periorbital, without combination. Because he's interested in the cases that we saw where we get very nice skin texture improvement, wrinkle reduction, but also volumizing and tightening. And that is what he's doing with high settings. Okay, other doctors, when they have cases of low damage, just refresh the skin, rejuvenate, resurface. Then you can use the combination and add some mesoproduct, you will get a good effect. But to get the full let's say, potential of the device. He's using it just like a CO2 at high settings. This is 14700, and you see how even on the forehead he's using 14700. The only place where he uses 10400 is around the eyes. The patient at the end of the treatment, I can just jump, is pretty happy. Now he's treating the eyes. She's smiling. She's happy. No EMLA.
No.
Very high settings. Second treatment, and she says, "I'm coming again." That's what we want from our patients. We want them like this. That's the trick of Tixel.
Ele não indica a maquiagem nos 2 dias, segue, mas nem protetor, protetor com base,
You don't recommend to put makeup after 2 days.
No, yes, to put makeup after a day or two. If you use very, very high settings, it's 2 days. But typically it's 1 day.
1 day. And sunscreen.
Makeup with sunscreen. When I say makeup, I mean...
Mesma coisa.
Yes, yes. Sunscreen is... You don't want particles in the skin when the crust has not appeared yet. But after the crust is there, which means that the epidermis is healed, we can put anything we want normally on the skin. Of course, sunscreen has to be applied after such treatment.
I saw some pictures about. I'm sorry. I saw some pictures about a performance in the body area.
Yeah, we have pictures. I don't show them a lot because I don't know enough about this. I don't want to be too exact. But we have flattening of the stomach. We have beautiful things.
And
it's a new area for us.
Okay.
Users are doing it.
And about the parameters?
High.
High?
High.
Yes.
On the body high, 12,600, 14,700. The body high.
Okay, like in the stretch marks?
Yes, they want high temperature. I can show you later, but we do have. But I don't know if it is reoccurring. I don't know enough about it yet. Our users are telling me knees. The knees are rough. Women have rough skin on the knees. They treat. It rejuvenates. It's fantastic. Here they work. Yeah. You will see more and more and more things coming. But we need to do more and more evaluations before we can say we can do that and that. The only thing that I'm really saying that seems to work well without really going for a study is the dry eyes, because that has logic in it. Dry eyes are treated with IPL, and it works. All the IPL does is to transfer heat into the skin. And of course Tixel does the same. Why is Tixel a better solution than IPL? Number one, you don't have the flash on the eyes. Number two, you also have, in a single device, wrinkle reduction and non-invasive blepharoplasty. So you have 3-in-1 in one device, so it's better.
Raphi, if the skin of the patient are very well hydrated or moisturized, do you believe the results are better?
No.
It's not a
better, yes.
Yes, because
for you mean in terms of the healing?
Yes.
Yes, of course,
Yes, of course,
always,
no?
yes. Hydration is the number one, as I'm told by doctors. I'm not a doctor, but that's what the doctors tell me. Hydrate the skin. I have very dry skin. It's very bad.
For example, the
But
doctor.
doctors want hydrated skin, and that's why we like to hydrate after the open channels with hyaluronic acid.
For example, the doctors sell the treatment for the patient, and the doctor should recommend for them, we will do your treatment after 1 week or after 10 days. It's better you hydrate your skin.
We say
until
hydrate
there.
four times per day for 4 days. That's what
Okay.
we're saying.
But it's not necessarily a pre-treatment? No.
Yeah,
No.
this is my question.
No.
No, yes, I was
Pre-treatment.
I was never told. It makes sense, but I was never told. You're right. It makes lots of sense.
Because it hits equally.
I agree.
It doesn't depend.
I agree that it seems to make sense to me, and I think this is a doctor for the doctor to decide, not for us. We make the device. We're not doctors. We know what we know, but that's all. We don't know more than that. We shouldn't talk about things that we don't know. If you think that it's better to hydrate 2 weeks before, let them do it. That's why you're the doctor, not us.
Okay, thank you. I would like you, please, to show us the presentation, a specific presentation comparison
To CO2.
CO2.
Except in drilling mode, we get a very similar effect. There's not much difference. We can go into details, but we're not interested in details now. But this is a few days after in the CO2, and this is the Tixel side. We understand what's going on. This has been subjected to carbonization and burning. This is a severe, much more severe side effect of this. That's the difference. And the end result is the same. If you look after a few months, maybe even Tixel is a little bit better because it's less trauma. And what we have when we look under a microscope, this is the CO2 burns, dark. We don't have dark rims in the channel, in the thermal effect zone, in the craters. We just have white spots. We see it on the skin, it's white spots. The CO2 looks like this, and in our case, it's just a white spot. No dark areas at all. The darkness is simply because of the temperature that we mentioned, high temperature, and that is because of the explosion, so it burns. That's why we smell CO2, and that's what we see. So to heal this is much more difficult and takes more time than to heal this. And underneath, we see that the skin has been really in trouble, which we don't see here. We claim that you don't need so much energy for the indications that we're treating. We can do the same with less energy. There are other indications where you need more energy, but maybe to drill holes but what I showed you works without applying so much energy. If you want, sorry.
Não sei se já foi explicado, mas o ablativo está relacionado aos milissegundos, ao tempo.
Tempo de exposição.
Ao tempo, né? Não à protusão.
Os dois,
A combinação dos
A
dois.
combinação dos dois.
Combinação
A partir
dos
de
dois.
quanto é ablativo? 10 com 500, é isso?
From what parameters you can consider
Ablative.
ablative procedure?
Okay, I will show you a presentation, and first I will answer, then I'll show a presentation. We think that the 12,500 and up is more ablative than non-ablative, and below it is more non-ablative. Okay, I will show you now all the histologies very quickly on human skin, extracted tissue, and I will explain what happens when we go from high to low. It's very simple to see. And then you will see what you're doing to the skin. An analysis actually we did it for the FDA to make sure we can answer all the questions that they have. So the depth in general is of our thermal effect is about 200 microns, and the width is about 400 microns. Typically, the ratio is 2 to 1. 2 wide, 1 deep. 400, 200. That's typical. Okay. Now, if we look at we'll only look at times 20. This is the maximum that the machine can provide, 18 and 1000. What we see here is an effect which is wide, and there is a very strong, uniform, thick coagulation layer under the ablative crater, under the ablative effect. Why do we say ablative? Because there's no epidermis. You notice that the epidermis is vaporized, it's gone. And we have lots of coagulation, and anyone can see that this is solid. That means that there is so much heat that it created both ablation, that means eliminating, removing the epidermis, and coagulating the dermal area below the papillary dermis. That's the maximum, okay? Now we go down. Now I will simply go down. This is for 14 and 700, which earlier I suggested to use this as the maximum. And this is 14,700 double. This is 14,600. In this case, we still see ablation, of course. There is no epidermis, but we see a little bit less coagulation, a little bit shallower. Okay? Jump now to 12,500. This is the first case that we see epidermis remains, but it's crushed. It didn't disappear. Okay.
Specifically in this with 12,500.
Yeah. And if we go further down, 12,300, we're already starting to see something that I call an open channel, because the coagulation zone is narrow. So look at this. What is the difference between this and the other ones that we saw so far? I think I see at least three differences. One, there is only partial removal of the epidermis. Some epidermis remains. Two, the coagulation zone is not so thick and not so uniform and not so wide. The upper area was damaged at around almost, this is 100 microns, this is about 400 microns. But underneath, the coagulation zone is narrower. You can see this. If we go back, you will see that the coagulation zone in the stronger settings was much wider. So this is not really a channel. This is a thermal effect, but there's a secondary barrier here which is coagulated tissue. And when you go down in settings, you see, or even double pulse, it still leaves us, like here, a narrower coagulation. So the effect becomes more like this. When it is high settings, it's more of a square. When the settings are low, it becomes like a triangle. And if we go down further, 10, you see that it becomes more delicate. The staining is lower, the coagulation layer is fluffy, it's smaller, it's not much narrower. This is much narrower than what we had before.
So it's good for drug delivery?
Yes, from 8.6, 8.10 is good for even 12, up to 300. It's what we see is nice absorption. How would you know? And you can read the protocol by Dr. Natalie Fournier. How would you know that you have good, effective open channels? You simply apply the topical on the skin, and we will do it now when we treat. You will see that it's absorbed. It dries out very quickly. And you know.
And about the single and the double pulse?
The double pulse we don't use on the face. You can if you have very severe cases, if you're really sure that you have experience and you want to treat like an acne scar which is very deep, then what is a double pulse? A double pulse is very pronounced. You see that this is a double pulse. You see that's much wider. You see what it does? It further dries the area. It's another shot. Like, I have one case which is explaining it very well. This. You see what it did? Nothing is left. That's the double pulse. So it further dries for more energy. But it's not going to create any post-treatment side effect. It just is more severe in terms of the thermal effect, and the amount of energy going into the skin is almost double.
Rafi, in cases of severe acne scars or stretch markers, is it possible to apply the crisscross technique?
Crisscross is good.
Double post at the same time?
It's too much.
Too much?
Too much? Double?
Don't do double and crisscross. That's too much.
Yeah,
Too
it's
much.
too much.
Okay.
Let's think about. Let's think what we're doing. It's important to understand what we're doing. We have 81 pyramids, 1 centimeter square, 400 applications on the face, 400 times 81, 32,000 spots. 32,000 spots. Okay? Each spot, if it is 400 microns wide, it's a lot. Each spot is 400 microns. That's the thermal damage area, down to 200 microns. That means that we have a lot of regenerative power going on the face. Now we do this 4 times. So 32,000 times 4 times over 4 months. We're really giving energy to the skin, and underneath the skin, there's lots of action. I know it, we saw all the slides. Lots of fibroblasts and macrophage, and it's all boom, boom, boom. It's a lot. So it looks like a gentle machine, but it's doing what you need. Not too much, you can do less, but not creating trauma, but underneath you have lots of action. Because of the amount of points that you create. So if you do double and crisscross, that means that you're doing 4 times as much. Yesterday we spoke in the car about that. Today, about doubling everything. It becomes exponential. Then you will cause damage. We don't want that.
Okay. Rafi,
Linear. Make it linear, not exponential.
Thank you. We know that one of the most complaints about patients after laser treatments are hyperpigmentation. May I say that I believe the third most advantage that we can find in Tixel are obviously vaporization and not carbonization, less pain, less downtime, and the fact that we will not have hyperpigmentation.
Seldomly, very, very seldomly do we get hyperpigmentation. We only get it when the settings are too high. So it's very simple. Follow the protocol that I showed. This is based on experience of several, like 2 years. Always think about these settings as maximum. And in skin type, which is high, be careful and go down. Even at 8, you will get results. The nice thing about this is also one more point. We saw that we can get results in 2 ways. One is high settings. The other is low in combination.
Like a crisscross with double plus. If you use it,
No,
it's possible to have a hyperpigmentation.
Yes, but you can. But what I'm saying is a little bit different, and it's the way to work. If we want to treat severe photo damage and wrinkles, and we have skin type 1, 2, 3, we can do whatever we want with this machine. We will not get hyperpigmentation. Okay, we're safe. If we have skin type 5, now we have 2 choices. Do a combination treatment at 8, we'll never get hyperpigmentation, or do a 12-600, and then if you may get on certain spots, if you do double passes or on this area, you may get some hyperpigmentation. So what I think is that we will try to take the cases which are more pigmented into the low settings and combination treatment mode rather than the high settings. And this way, you, as a doctor, you will not get any problems.
Thank you.
For example, in a melasma, okay, you can perform like 12 to 100, and
8,400 mostly.
Okay, 8,400.
Yeah, not go to 12 with melasma, just 8 or 10 is enough.
8 or 10, okay.
Yeah.
And for example,
Even 8 is enough. Just open the channels.
okay, and in the areas that the tag is very strong, you can make a second pass?
The doctor that I work with from Romania, she does, but I don't think we need it. We did a test recently, and I tried that. We did a test with ALA. It's not really the topic here, but we did in one case say 8,400, another case 8,400 double pass. We wanted to see if we get more absorption. We didn't. So we're going to repeat that and publish it. So you will really have the guidance. But my intuition today is that 8,400 is enough for covering the area. What I do, I treat, and then I do like 6,300, which is very fast. I do tuck, 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 just a little bit more, just to make sure that everything is covered. And then you apply your cocktail or your hydroquinone, and it should go in.
Okay.
The less energy you apply in melasma, the better.
O protocolo com melasma é sempre com uma aplicação de
Sempre uma aplicação
sempre.
Sempre hidroquinona.
Sempre com a hidroquinona,
Sempre.
sempre.
Exatamente.
Okay?
Okay.
We covered everything?
Yes.
Thank you.
Patients are waiting.
Yes. Anxious for the treatment?
How many patients do we have? Two?
Yeah.
Okay, good. One is skin type 2 or 3, it's very simple. You have some photo damage on your skin, some pigments.